specializes in the diagnosis of disease through examination of tissues. And usually these tissues are obtained from a surgeon. So that's why we are called surgical pathologists. It's a skill set that combines both clinical knowledge, because you need to know the disease process in question from the clinician's point of view, and also microscopic analysis. So we are the kind of physician that holds onto a stethoscope for sure, but we also add the microscope to it. So we have a little more going than the average physician, I guess. And our role is essential in guiding treatment decisions based on the findings of our diagnosis. So these images are from the lab here, but it pretty much is cut and paste. I mean, any lab, any surgical pathology lab you go in the entire nation in the world, they look like this, you know. So it can be cut and paste from anywhere. This can even be Paris Sound. I remember while I was a PA in Paris Sound and I was doing some work, and there was this man that came in to fix some things, you know, some electrical repairs, and he said, "Oh, I've also done some work at the U of T, and this place looks exactly like the U of T. You have so many tissue specimens, so many tissue jars." Yes. So this is what the surgical pathology lab looks like. So we start with grossing the specimen, what this man is doing, and we process the specimen, and eventually the surgical pathologist or the pathologist will examine the processed tissue to make a diagnosis using the microscope. Okay, so going to prostate cancer itself, which is the topic for today. This is a cancerous or malignant tumor that arises from the prostate gland. So that's just pretty much what it is. But you know that there are different aspects of the prostate gland. The prostate gland is made up of different kinds of cells. So depending on the kind of cell the cancer arises from, the name of the cancer, the malignant lesion, will be different. But for the most part, like over 95% of cancers arising from the prostate arise from the epithelial elements, from the epithelium of the prostate gland, and those are called adenocarcinoma. So I'll use the term prostate cancer and adenocarcinoma interchangeably for this presentation, just to clarify things, because it constitutes most of it. And prostate cancer or adenocarcinoma is the most common non-skin cancer and the second cause of cancer-related deaths in men. There are millions of cases diagnosed globally every year. From the Canadian perspective, and these are figures from the Canadian Cancer Society, 1 in 8 men will develop prostate cancer during their lifetime, and 1 in 29 will die of the disease during their lifetime. So that is a huge number of cases. You see, 1 in 8, that's pretty concerning. And in 2022, the last figures I got, they gave figures of about over 24,000, almost 25,000 Canadian men are expected to be diagnosed with prostate cancer, with just shy of 5,000 expected to die of the disease. So now let's really know where the prostate gland is and what we're actually talking about. So this is the prostate gland. It's an accessory sex gland located underneath the urinary bladder. So this is the urinary bladder, and this is the prostate gland. And its function, it's to make up a large volume of the semen that is ejaculated. And it produces this fluid, which also nourish the sperm. And it also acts as a passage of urine from the urinary bladder to the outside. So, and it's a chestnut-shaped, firm, and rubbery small gland. This is an image I took. This is the prostate gland itself when it's outside the body. And there's just this is the vast difference, and this is the seminal vesicle. These are just organs that allow emission of sperm to the outside. But this itself is the prostate gland. And it's about 20 grams, not too big. but it could go larger depending on disease. And it's divided into lobes and zones. I just gave a figure here. And for the purposes of this discussion, we'll just know that the peripheral zone, which is this portion outside, gives rise to most prostate cancers, like 70%. And that's why it's amenable to examination, which we will come to later. We'll talk about that. And then in terms of the histology, because we are pathologists, we do a lot of morphology, including histology. We have the glands, which are these rounded structures. And then we have the supporting tissue, supporting stroma. And this is a benign normal gland. I've made a high power image. But the important thing to note in these images is just simple. There is the inner lining of cells and then the outer basal cells, which are a bit flatter out here. Sometimes it's difficult to see it. So we do have some special markers which we apply on the tissue to highlight the basal cells. So these are them round. And what is the function of all this? Why do we do that? Because in prostate cancer, there's loss of this. So in a prostate cancer gland will lose this brown staining, and you won't just see any brown staining. So that's important when we come to the diagnosis. I'll show you much more images as we go on. So in terms of classification, I'll just give a brief classification. I've mentioned that. So we have cancers or malignancies that arise from the prostate itself. And again, depending on the tissue of origin, they're given different names. And also there are some, another group of tumors, broad group, which are the lymphomas. Pretty much in ordinary terms, people call them blood cancers, cancers of the blood, but they can also arise from the prostate, so lymphomas. And then there are tumors that arise from outside any other part of the body, from the urinary bladder, from the colon, any other tissue, and they find their way and into the prostate. So those are called the metastatic tumors. So this is just a brief and broad classification, just for us to understand. So what causes prostate cancer? There are many causes, and they are known, and many that are not known. A lot of research is going into it, but in simple terms, up to 10% of prostate cancers are hereditary, meaning that the mutation, the aberration is found in families. And so these families tend to have men in these families tend to develop cancers at a younger age than the average population, maybe like in their 40s, maybe even earlier. And there are different kinds of, from the point of view of the causation, there are different kinds of mutation in different genes that will give rise to prostate cancer. I listed them, but I don't think we'll go too deeply into them, but it's just important to know that there are genetic mutations that cause prostate cancers. Also, exposure to chemicals. There are different kinds of chemicals and dyes we're all exposed to, and they can give rise to prostate cancers. And a big influence in prostate cancer development is hormones, androgenic hormones, the male sex hormones, testosterone and DHT. And again, the relationship to hormone levels are quite complex, but it's been pinpointed as one of the reasons for causation of prostate cancer. This is a diagram that just shows, in visual form, what happens for prostate cancer. So you have the normal epithelium, as I showed. You have the cells inside. They're bound by the basal cells. And then the neoplastic process sets in. The epithelium proliferates. They tend to proliferate and become abnormal. Eventually, they break through these basal layers. There's now a bit loss of the basal layer. And then eventually, these cells, instead of being limited within the basal cells and the basement membrane, they find their way out, into the stroma and sometimes even beyond to other tissues. So this is just a visual representation. And carcinoma cells, cancer cells, they proliferate. They are not under normal control of cell growth. They just do their thing. They do not stop. And that's what causes their adverse effect. Other risk factors include age. Again, the older you get, the more likely you are to get cancer and other kinds of malignancies. And in prostate cancer, it's uncommon before the age of 50, and most cases arise from 50 onwards and the older you get, up to 60% of cases are found in men 65 and older. Diet and lifestyle has also been implicated, as in so many other diseases: high-fat diet, low vegetable and fruit intake, physical inactivity, and so on and so forth. And also, there's been noted to be a higher incidence and mortality rate in Black men than in white men of European descent. However, it's also a lot of cancers are diagnosed in the more developed parts of the world than in the lesser developed parts of the world. They believe that it's not because there are more cancers, but because there's more screening and more advanced technologies to identify these cancers. So, in a nutshell, there are so many risk factors and conditions that play a complex role to cause prostate cancer. So, in terms of clinical aspects, you might wonder, someone with prostate cancer, what are the symptoms? How does the doctor diagnose it? So it's often asymptomatic in early stages. In fact, as they say, quite a number of men die with the disease than of the disease, because even in autopsy findings, they have seen a higher rate of prostate cancer in men that throughout their lives, they were totally normal. They didn't have any complaints. So the bottom line is, it can be asymptomatic in early stages. I'm totally fine. I go to my doctor and they do what they do, and that's it. Oh, I've been diagnosed. That scenario is not uncommon. But when people do have symptoms, then they tend to have increased episodes of urination and episodes urgency, where they can't hold down the urine, and they have this urge to quickly pass urine, or else they will wet themselves. And the urine stream is a bit weak. It's not as, the jet of urine during micturition doesn't come out the way the man is used to. So those things might, in some cases, point to that. And then when it's a more advanced kind of presentation, will be hematuria with blood in the urine, or hematospermia, blood in the sperm during ejaculation. So that definitely is abnormal and should raise alarm. Men can also have erectile dysfunction, and when it's really late stage and the cancer has actually spread to the other parts of the body, then there can be symptoms of weight loss, fatigue, bone pain, and sometimes I've actually seen a case whereby the man was totally fine and he just took a step and fractured his bone, and that was how a pathologic fracture was discovered, and eventually was worked up and the diagnosis was made. So, but on the part of the physician, examination will find enlargement of the prostate nodularity. I'll talk about how that examination is done. Firmness on digital examination of the prostate. In the lab, we will see elevated serum PSA, prostate-specific antigen level. That's a marker, a protein in the blood that is identified, when you give your blood for test. And then imaging, multi-parametric MRI might also detect some suspicious areas within the prostate. And then finally, confirmation, the diagnosis itself is by biopsy from a pathologist. So that's how it goes. So what is the role? What does the pathologist do in all of this? The pathologist is actually the one that makes the diagnosis. The clinician may suspect it, but we actually confirm the diagnosis, and that's the standard, really. The pathologist also, during his examination, not only makes the diagnosis proper, he also gives other characteristics of the tumor, of the cancer, that will help in, finding out the prognosis of this patient, how this patient might fare. So we do things like grading and staging. Grading is how we call it the degree of differentiation. Just in simple terms, will be how the prostate gland or the prostate tissue, how it resembles, how much does it resemble normal tissue, or how, so that would tell us that will give an idea to how the prognosis of the cancer. Is it going to, a low grade, a well-differentiated tumor will tend to be more indolent, it will not recur, or the risk of recurrence is low. And then a poorly differentiated tumor usually is more aggressive with higher risk of recurrence and maybe even metastasis. So the findings from the pathologist guide treatment directly, and I'll get into that later. And also we do collaborate with our clinicians to ensure cohesive care. We participate in tumor boards where we explain some of our findings, which will influence tumor and treatment. And also there's a role for research. There's always ongoing research. And so again, as I said, when you come to the lab, it's not only the surgical pathologist that will see you. The pathologist, generally speaking, also deals with serum PSA measurements. And the type of specimens we use in making our diagnosis are what we receive. Many of the specimens, to start with, will be a core needle biopsy because you need to have a tissue specimen to actually evaluate. And then when the diagnosis is made, depending on the treatment the patient receives, if the prostate is totally resected, totally taken out, then we'll get a prostatectomy specimen. If not, and then in some cases, a transurethral resection is done for some other indication, usually for nodular hyperplasia, benign prostatic hypertrophy. That's a condition whereby the prostate is enlarged but not cancerous, and it affects urinary stream. And so sometimes when a surgery is done for that condition and the specimen is sent to us, we now look at it and discover that yes, in addition to the other condition, the nodular hyperplasia, the patient has a prostatic carcinoma. So those specimens, those diagnoses are usually incidental. And the diagnosis is made by gross examination and also by microscopic examination. In microscopic examination, we have different methods, including the H&E, hematoxylin and eosin is the most common stain. We have to stain the tissues to appreciate what we see. I'll go to different stains later. And also we have other techniques like immunohistochemistry. These are also other more advanced kind of stains that we use to elucidate what we are seeing. And this is just a small stack. These are where our slides are kept, and we take the slides from this stack. So this is what sometimes my day looks like, going through specimens from tall stacks. Okay, so again, as I said, usually the most common specimens are needle biopsies. But in terms of, but when we do get resection specimens, we now have, so a needle biopsy is just a thin strip of specimen. You really don't see much until you examine it microscopically. But when you now get the specimen itself, you now get to appreciate what prostate cancer looks like, on gross. So here we do have an example. These nodules are those of prostate cancer, and they usually present as ill-defined nodules when you see them. Sometimes they're not very apparent. They're just some, some small blushes or so on the cut surface of the prostate. So this prostate has been cut through. And so these nodules represent carcinoma, as we can see. And they can also go eventually invade beyond the prostate. Like you can imagine, this is the capsule. Some of these tumors may even invade beyond, and then you might even get a nodule, or there might be attachment to surrounding structures. They can also spread to nearby tissues or organs like lymph nodes. So the lymph nodes might also be enlarged, and we do receive those kinds of specimens. Under the microscope for a pathologist, again, this is the pathologist viewpoint of prostate cancer. You see this. As compared to the normal, which we did see earlier on, in prostate cancer, you have crowding of the glands. So these glands, they're just too many and too much. And they have some unique kind of appearances that we recognize. Like, for example, there's this tufting of cells into this rounded gland. That is one of the features. There are many features, but that's one of the features. When you go a bit closer, sometimes you can see glands. You can see these glands. This is a bit of nerve here. And when you have glands that wrap around the nerve, that is definitely abnormal. If they wrap all the way around, that's one of the features of prostate cancer. Another feature here, when we really go close, I try to make this as large as possible. But here, I just wanted to show you exactly how we see this thing. So here you have a gland. This is a normal gland. It has 2 layers of cells. It's a bit thin, but this is normal. So you can see the cells, round nuclei, small. Look at the nearby prostate cancer. See this nuclei, they're really big compared to this, you know, and they have prominent nucleoli. There's this dot within the center of the nuclei that are a bit more prominent. Look at the benign, you don't see that. So that's one of the signs of cancer. And sometimes to actually be absolutely sure, again, this thing comes in different, they appear differently each time. You can now do a stain. This is a stain for basal cells. And here you have the normal gland where you have a complete circumferential brown staining of basal cell. Nearby, you have the prostate cancer cells, and they are totally lost. So this is, there's no basal cells surrounding this. So this is a loss of basal cell, which is one of the features of prostate cancer. So I just wanted to use this slide to show some of, again, what I mentioned before. This is the usual stains we do, hematoxylin and eosin. And these are some of the immunohistochemical stains to highlight what we see. This one is called NKX3.1. There are different kinds of names they have, but they serve different functions. So this will highlight the prostate cells. And then this is, again, that marker I showed you earlier on. It highlights the basal cells. Here, the basal cells, again, is intact. Here is lost in prostate cancer. So these are some of the tools we work with in pathology. So to illustrate my point further, I'll just use different clinical scenarios of patients presenting with prostate cancer so that we, so I put it in perspective or in context. So here, this is screening. This is a vignette for screening. So we have a man, he comes in for his routine physical with his physician. He has no symptoms, and he was screened, and PSA is normal, 3 nanograms. So that's within normal range. And so what are the screening, how is prostate cancer screened for, and what are the recommendations? In Canada, and also in pretty much everywhere, there are different recommendations, and sometimes they seem to contradict, but I'll explain why. So the Canadian Urologic Association does recommend screening, and you start from age of 50 to about 70. Generally, you screen men who have a life expectancy of about 10 years, so 50 to 70 is just about right. And you screen with a PSA, prostate-specific antigen level. A PSA, of course, is that substance found in the blood. It's produced by the prostate, is an enzyme, and is detected in the blood. In a normal scenario, it will be less than 4, and with cancer, it goes higher than 4. Again, it's more complicated than making it, but that's just the overall idea. However, the Canadian Task Force on Preventive Healthcare, the last time I checked, they do not recommend screening with PSA recommend against PSA screening for men aged less than 55 or 70 years and older, and against routine screening for men 55 to 65. So they do not recommend routine screening. So it's a bit conflicting. So really the bottom line is this: at the end of the day, it's a discussion the patient will have with his physician. The need for screening, the risk for screening, because screening in itself is not, doesn't come with its complications, because you can overdiagnose cancer leading to overtreatment. And one of the treatments, one of the complications will be problems with sexual function, which can be quite problematic for the patient. So that's why there's this, conflicting or seeming conflict in the kind of recommendations. But the bottom line is it has to be a discussion the patient will have with their physician. So how is this taken care of? Again, I mentioned the PSA, just a blood test, but digital rectal examination. Now, some authorities say that digital rectal examination should be part of screening, and some say it shouldn't be. However, most agree that it should be part of the examination process. You know, when you're examining a patient who might be at risk for prostate cancer. And this is a diagram that shows it. Digital rectal examination. The prostate, because of its location, is not easily accessed. However, a finger through the rectum can palpate the prostate, as you can see here. And then when you palpate, you do feel for any abnormalities that you feel on the prostate. When a prostate is cancerous, it tends to get firmer, harder, irregular. It might be fixed and things like that. So those are the things the physician looks for. And it gives him an idea, at least a level of suspicion for which he can recommend for the test. So this is how it's done. And as you can see from this image, it's something that many men do not like. You know, it's not, even the doctors might not be too enthused about, you know, doing this examination from its very nature. But again, the good thing is that there's always another test, which is the PSA, that can actually screen for it. And one of the things about the digital rectal examination, again, as you can see from the image, you can't have access to all of the prostate. So there can be a cancer and you might not detect it. So, you know, it has its own issues. And if there's any reason to suspect from the PSA or the examination, then a prostate biopsy is arranged for. Again, this is a diagram to show you how the biopsy is done. Because again, of its location, you can either go through the perineum, you know, poke a needle through the skin, through the soft tissue into the prostate and take a core of tissue, or you can go through the rectum and then take a core of tissue, usually guided by imaging to, you know, pinpoint the exact area. And then it's usually done systematically over various parts of the prostate. And if there's a lesion, there can also be a targeted biopsy. And these are some of the needle cores, which we will now look at under the microscope to make our diagnosis. So grading of prostate, there's this big, there's a score, Gleason's grading and Gleason's score. This is the man, Donald Gleason, that came up with this score. And it's just a way of figuring out the degree of differentiation. The higher the score, the higher the score, the less differentiated it is, and the likely, the more aggressive the prostate cancer can be. And so you will see in the report, if I've ever looked at the report, you see things like 3 + 3 = 6. So this is a pattern 3, and the major pattern, the pattern, I'll show you the patterns later, but the pattern that is predominant will be written first. This less predominant pattern is next, and then you add this up and it gives you a score, 6, 7, 8, which range from 6 to 10. So this is just a schematic image of the different patterns, you know, and we look at the way the architecture, the way the glands appear. If it's small and uniform, well-defined glands, you know, that will be a pattern 1, 2, and 3. And as you go higher, you know, 3, 4, 5, the glands tend to be less well-formed. And sometimes there are no glands that are formed. So I'll give you some images to go. So this is a pattern 3 cancer. Again, these are malignant cells. And as you can see, they are well-formed glands, various shapes and various sizes, but they are all well-formed. You can see they are round. And there's a space. They are not like jumbled up together. They're not mashed up together. There's a decent amount of stroma in between. So, and they are all separate. So this is a pattern 3 + 3, because the major pattern is 3 and there's no minor pattern. So 3 and 3. And this is generally a low-grade cancer. In fact, there's even some discussion in the community as to whether there was actually a time there was a discussion to maybe not diagnose a pattern 3 + 3 as cancer, because it's low grade, it's indolent, it tends not to progress, And all the physician might opt to do might be just to follow up the patient. Again, that's with discussion with the patient. Some patients just want it out. But there's a role for, active follow-up and nothing else really, because it's usually low grade. But as you go on, some patients might even have a higher PSA level, again, as in this vignette I gave, and then other patterns can emerge. This is a pattern 4. Again, as compared to the pattern 3, in this case here, you see this gland. There's more stroma than glands. They're just some small glands. They make an attempt at forming, there's some cells, and they make an attempt, very poor attempt, as we call it, at gland formation in the stroma. So most of this is 4. This is another appearance of Gleason 4. Again, you can see it's really confluent. The glands are not single and separate as before. They are just confluent. And there seems to be, this cribriform sieve-like kind of pattern. And again, this is another kind of pattern. So a pattern 4 itself is a higher grade pattern. It indicates a more aggressive cancer. And this pattern here, the cribriform kind of pattern, actually in itself even denotes a more aggressive kind of cancer than the usual pattern 4. So in our report, we actually specify whether we see a cribriform pattern. We do all that because usually, if we see a pattern 4, especially with a cribriform pattern, that might be an indication for definitive therapy, usually with a resection of the prostate, usually. So those are the kinds of information we present in the report. And even when the cancer goes even higher, a higher grade pattern, you see things like for a pattern 4 and a pattern 5 cancer coexisting, or all of it is pattern 5. So we have seen a pattern 4 before, and again, a pattern 5 is even more aggressive, higher risk of recurrence. And in a case like this, unlike a pattern 3, there is definitive treatment is usually indicated. Again, you make your treatment decision based on also the patient's condition. If the patient is frail and things like that, you might tend to be aggressive. But in the usual situation, a pattern 4 or 5 will lead to a definitive treatment, as opposed to, for example, a pattern 3. So these are some images to show pattern 5. Again, they appear in different forms, but for this one, as you can see, this is a gland. It's been taken over by these malignant cells. So, but let's just keep this aside. In here, as you can see, you hardly see any gland formation. Instead, you can see single cells, cancer cells, or single file of cells, or single clusters of cells. There's some attempt at gland formation, but really poor, but many of it is just like single cells. So this is a pattern 5, when the prostate the prostate cells themselves cannot even form glands. This was another look for pattern 5, where you have necrosis in the middle of a gland. And the gland, of course, has cancer. So there's necrosis, meaning dead cells. So you have dead cells in the middle of a gland, which itself is cancerous. Again, pattern 5 has different kinds of appearance, but the reason why these patterns are important is that they give a degree of differentiation, which informs treatment directly. Okay, as I've already mentioned, for high-grade prostate cancer, definitive treatment and maybe multimodal treatment, meaning surgery in addition to radiation and hormonal therapy. And close monitoring post-treatment is essential. And there are certain times that a patient receives therapy, usually androgen deprivation therapy, before or maybe even after prostatectomy. And yet, the cancer not only persists, but actually progresses. So in this case, the classic scenario would be a patient who has previously had androgen deprivation. Androgen deprivation, again, from the etiology I mentioned before, androgens meaning the male sex hormone. In simple terms, they feed prostate epithelial cells. They are the reason why, prostate cells, they lead to growth. They encourage growth and maintenance of the prostate epithelial cells, and also cancers. So one of the things you want to do sometimes is to deprive the prostate cancer cells of androgen. So you give them androgen deprivation therapy. But now, a patient might come, even despite this androgen deprivation therapy, there might be an initial decrease in the level of his PSA, meaning that it's responding to treatment. But later on, the PSA rises and really rises. So in this kind of situation, there might be a need to do a biopsy of the prostate bed. After the prostate is taken out, the tissues around where the prostate is, and you take a biopsy of it. And in those cases, you might see a tumor, and the tumor looks a bit different from all the pictures I've shown you before. They look really different. I'll show you the images. In this case, you have to now go beyond just androgen deprivation or hormonal therapies, because these tumors are resistant to hormones, and you have to give chemotherapy, which is all drugs that work through different mechanisms, killing the cells. And this tumor, as you can imagine, has a poorer prognosis. The outcome is not that, it's worse than the usual prostate cancer. So this is an image. Again, this is our view of those kinds of tumors. As you can see from the image, it hits you that is different. You don't see glands. All you see is a sea of blue, sheets of blue. There's some spaces here, but they're not actually glands. These are stroma. The remnant of the stroma that has not already been overrun. I made a bigger image here, and you can see the cells are just sheets of cells, coast to coast. There are cells everywhere. There are these dark dots. They are mitotic cells. They are mitotic figures. It means that the tumor is really, really proliferating. In some areas, you could see dead cells, necrosis, tumor necrosis. Like here, I think there's some tumor necrosis. They don't even, when they are dead, they don't take up stain, so they look a bit paler. So this is what it looks like. And then we do some stains to actually confirm it. These are some of the stains. Sometimes these tumors actually, NKX 3.1, as I pointed out, is the stain that marks prostate cancer. They actually lose staining. You can see it's all pale. It's not brown like the usual prostate epithelium I showed you. And then they acquire some other stains, neuroendocrine markers. And so, yeah. Sorry. So that is just a bit overview of how we see prostate cancer. There's so much more to discuss, but I'll just go to some of the challenges, pitfalls and challenges that we face as pathologists in our diagnosis of prostate cancer. You can overdiagnose prostate cancer. And again, as I said, because some of the cells appear, some of the glands, when prostate cancer form glands, they do look like benign glands, and it's very much possible. That's why we have to rely on some other techniques to detect the cancer. You may also miss a diagnosis of cancer. You can overdiagnose a cancer, and you can miss a diagnosis of cancer. You can miss the classification. Remember, I showed you pictures of grading, but to a degree, this grading system is subjective. Someone may say, you know what, this is a well-formed gland, and another person will say it's not really well-formed. So there's a degree of subjectivity to all this. And the misclassification might result in the patient not receiving appropriate therapy. And that's why a collaborative effort is always put in place by pathologists. When we are not sure, we think this might be a bit controversial, we send it to a colleague and say, hey, can you have a look and give me your opinion? We do that a lot in pathology. So the diagnosis of prostate cancer, the pathology of prostate cancer is really very complicated, and you need a lot of collaboration to be sure you're on the right path. And some of the challenges again is that you can have a missed lesion. If the biopsy needle misses the cancer, all you see is benign. It doesn't mean the patient doesn't have cancer, but the biopsy, is missed, because this organ is deep-seated and is not very accessible. So these things do happen, and the biopsy takes only a fraction, 1,000th of tissue, right? So you can imagine that can happen. And there are some technical limitations, including pre-analytic factors in specimen handling and transport. And so for the rest of the clinical community, specimen handling and transport is quite important in diagnosis, not just only of prostate cancer, but generally in the diagnosis of any kind of condition in surgical pathology. So that's why I made this slide, just as a message to put across to all of us. Again, I mentioned the sampling and all that. Then immediate fixation in formalin preservative, it's very important. Correct identification and labeling of the samples is very important. If a sample is taken from one part of the body, for example, and is mislabeled as another, it could result in some problems. Timely transfer of the specimen to the lab is important, to make sure the specimen is well preserved so it can be processed and so on and so forth. And also very important, all relevant clinical information needs to be given to the pathologist. Clinical information to us, it's the same, pretty much the same as when a patient presents before his physician and gives his symptoms. If the patient does not communicate his symptoms properly, the physician may have problems with diagnosing what the patient's condition might be. Same thing for us. If the relevant clinical information does not accompany the specimen, we may have problems in arriving at the right diagnosis. Because again, the diagnosis is not just only what we see in the microscope. It's also the clinical information, and that's why that's why the pathologist is also a physician. We do rely on our clinical knowledge, to arrive at our diagnosis, including finding on imaging. If there was any relevant imaging findings, everything, like the way a patient will tell his physician his problem, that's the kind of information that needs to be given to us to make the accurate diagnosis. And again, how does the surgical pathology report influence management? Again, the diagnosis proper, which I've talked about, the Gleason score, the right score, treatment varies. This Gleason score, which is the degree of differentiation, has a huge influence on treatment. And also there are certain other things detailed in the pathology report that the clinician looks at in order to arrive at the right treatment. Again, if there are things like perineural invasion of the prostate cancer, a large tumor volume, lymphovascular invasion, you see the cancer cells within blood vessels. And if it's a resection specimen, there's positive surgical margins, meaning that there could be disease still left in the patient because it was not all resected. There's still tumor at the plane in which the tumor was, or the prostate was actually cut into, resected. So these are some of the additional information in addition to the diagnosis and the staging and the grading that are important to management. And of course, the stage. The stage is how progressed, how far the disease has come. So I'll just do a few slides just to go through some morphologic mimics of cancer, just a few. It's in no way exhaustive. So this is a core biopsy, and it shows this. If you look at it, it looks a bit concerning. You see these haphazard glands. They look haphazard. They don't look like normal prostate glands. And if you look closely, they look a bit haphazard. But when you really look closely, these are normal seminal vesicle. Again, part of the way to recognize them is that there are these granules, lipofuscin granules within the cytoplasm. So that's normal seminal vesicle, and it's normal. It's not cancer, but it could look frightening, when you look at it from afar. Nodular hyperplasia is also another condition affecting men. The prostate grows big and impinges on the ability on the patient to pass urine. And when you look at it under the microscope, so a patient presenting with nodular hyperplasia, the clinician might think, hey, does this person maybe have cancer? Or is there cancer along with the nodular hyperplasia? And under the microscope, it looks different. Sometimes you see a nodule, well-circumscribed nodule without glands. And other times you see, again, it's a bit nodular. You can see the rim. with a lot of glands. And sometimes the nodules, there's some hemorrhage and infarction. So it looks a bit different under the microscope. In some patients, they could have some pain and enlargement and swelling of the prostate. In this case, there's acute inflammation with abscess, prostatic abscess, and it can lead to a lot of pain and discomfort, and also increased levels of PSA. And this is what you get. There's a lot of acute inflammation. There's abscess, overrunning the gland, but this is not cancer. And also, there's cases where, again, elevated PSA, the patient has some complaints relating to, discomfort. He has some pelvic discomfort. He's an older individual. And this is a core biopsy that was taken of such a case. And what we see is inflammation, granulomatous inflammation. These are like big giant cells. This is not malignant. That's just the bottom line. But it can give concern for the clinician and even for the pathologist, because when you initially look at this, you think, where are the glands? Like something is wrong. But when you really look closely, you see these big cells and they're all benign. And also sometimes there are some hyperplasias that affect some of the glands in and around the prostate. Again, this looks a bit different from normal prostate. There are a lot of glands. It's all very busy, and you're wondering what could it be. In a case like this, you may do a stain. Again, look at the basal cells. It's all intact, and you know that this is benign. This is just a mucosal gland hyperplasia. And also there are other kinds of hyperplasias that affect the prostate. It's a bit technical, but the point is there are some things that on the first look might appear like cancers, but no, they are not cancers. So there's no need to worry too much, at least for cancer. So what's the future of prostate cancer diagnosis? What are some other tools that a surgical pathologist can use? Then we're now in the era of computer software, artificial intelligence, and they can actually make diagnosis. And here in the United States, they have been given FDA clearance for that kind of use. And there are some other more complicated genomic testing. And again, advances that happen in imaging, surgery, treatment, all add to the diagnosis and the treatment of prostate cancer. So in summary, I know I've said a lot of things, but I've taken you through prostate cancer through the lens of a diagnostic surgical pathologist. And I've told you ways how to understand what the prostate carcinogenesis is, the carcinogenic pathways are. I've taken you behind the scenes in surgical pathology to see how a diagnosis is made. I've talked about the diagnostic impact in terms of the Gleason score and some other elements. I've also mentioned some challenges and pitfalls that we face in our diagnosis. And also in all of this, I've highlighted the pathologist's role. So that's the summary. I do acknowledge Dr. Kasim. He's my mentor and he's my very good friend. And I enjoyed my time working with him in Paris Sound. And I also still maintain good contact with him. We see from time to time during conferences. So I thank him very much for this. Also, Kathy Hammer, I also thank her. She has been working with me for months now behind the scenes to set this all up. So thank you. And I also give my acknowledgement and thanks to all those who are tuning in today. And it's almost time for questions. But before I go, I just wanted to share a few images of Paris Sound. Everybody talks about the snow, so I won't beat you over the head about the snow, but I'll beat you over the head about the ice. We actually, while I was there, this was Wabuno Beach, I think. The water froze over and we did some skating with my kids. You can see them with their hockey skates. And look at me looking like a real pro, but I am not that good. I still fall from time to time. So that's a fond memory of Paris Sound. They said it happens once in 25 years, and it happened in my time. And also, this was a memento that was given to me before I left, a T-shirt. I still have it. I love it. I hardly wear it. Actually, the first time I wore it was last year. And my wife said, why don't you just wear this T-shirt? Like, do you want to frame this or something? So reluctantly, I wore it. Not because I don't want to wear it, but I don't want it to wear out. So I wore it a couple of times, washed it a couple of times. It's fading, and I say, you know what, I'm keeping it back in my locker. So yeah, this reminds me of Paris Sound. Thank you very much to everyone. These are some of the references I used. And I think that's about it. Thank you.
Okay, we'll open it up for questions. If anyone has any questions, please unmute and ask, or you can put it in the chat. I'm not hearing any questions. I'm thinking you did too good of a job. You explained yourself well.
I hope so. But if they have any questions, they can always reach out to you and you can reach out to me. I'll be happy to answer their question. And Dr. Kasim is always there. They can always call, give him a call and say, hey, we want more explanation. So yeah.
Okay. Last call for questions.
Oh, his phone is muted. Dr. Kasim, your phone is muted. The microphone. His microphone is muted. You have to unmute your.
It'll be in the bottom left-hand corner, the little microphone. Oh, Donna's behind you.
Okay, Donna is saying hi, Nomberi.
Hi, Donna. Long time.
How are you?
I'm fine.
Very nice
Good.
presentation. Very
Oh,
good.
thank you. Thank you.
Thank you very much.
Nomberi, I just wanted to comment, since you've been in the subspecialist in urologic pathology, what's the rate of radical prostatectomy? Is it steady or is it going down?
Oh, that
In
is
terms of number of specimens you're receiving.
Yeah, here, okay, let's put it this way. To be absolutely categorical, I have to go through the or documents and do a little bit of that. But in terms of the workload is not getting less. That might be because our service here is expanding, but I do not see it as getting less. So I think it might be holding steady, but again, I might need to confirm that. But just wondering, why do you ask?
The reason for my question is because there is this move, from manual radical prostatectomy. Surgeons went into robotic prostatectomy, where the surgeon just guides and then the robot sort of does the dissection around. The main reason for bringing that in is that we found that the robot will be more fine-tuned in how it goes around the prostate, because the major complication, one of the major complications of radical prostatectomy is loss of libido, impotence, all due to the damage, and also hemorrhage that is done to the nerves surrounding that. But over the years, and from the conferences that I have attended, they find that they're increasingly finding that even though immediately when the robotic ones are first introduced, people were excited that, oh, they'll be better than the manual. That is now finding that it's actually equal, that the robotic is not doing any better. And I'm hearing from a few surgeons, two of them my classmates, who have had, and they were urologic pathologists, and saying, look, if I had known, I wouldn't have had radical prostatectomy. And that one of them, who is in the States, told me he's not doing them anymore. So that's why I put that question to you.
Oh, okay. Here at Rochester, all our radical prostatectomies are robotic. So we have had that for quite some time. We don't do manual, to the best of my knowledge. Yes, and as you said, and the surgery for this is not benign. So that's why, as I said, there's sometimes some conflict on do you screen and how do you screen and stuff like that, because it does come with its complications, which could be quite severe and affect the quality of life. But again, I may have to reach out to the surgeons to see, what they are doing. But as I said, from my point of view on my desk, actually, I have a couple of prostates that are still sitting here, so it's still holding steady, I think.
Thank you.
But thank you for that. I'll follow up on that.
Any late questions? If not, Kathy, can we end it? I just want to thank everyone for coming to this excellent lecture that Kathy actually working with Numbere. I was just in the background. And I think it's been one of the best that we've had so far in our presentations. I know you also do some other subspecialties in pathology apart from urologic pathology. And one of these days, we will bring you to Paris Sound to speak to us at one of our dinner talks.
Okay.
And I think just to make a correction to your opening slide, you said you were not going to be receiving money on this one. I think Kathy would probably say no. There'll be some stipend. The conflict of interest is not about getting money for talking. It's about letting the money influence what you tell us. Thank you very much, Mumbere,
Okay.
and everyone in attendance.
Okay, thank you. Thank you so much.
Thanks.
Thank you both very much. And just a reminder, our next set of rounds will be November 23rd with Dr. Megan Davis, who's going to be talking about environmental sustainability at the primary care level.
Thank you
Okay.
for having me.
No, thank you so much for attending and presenting to our team.
Okay. Bye-bye.
Thank you.